Good
evening, all. Welcome to iFocus Online Lecture 278, the 19th in the Uvea Module. Today we have an international masterclass by the legendary Professor Daniel Vitor Santos from Brazil on ocular toxoplasmosis. May I now request Jyotirmay Biswas sir to please introduce the speaker for today.
It's indeed my pleasure and privilege to introduce my very good friend, Professor Daniel Vitor D. Vasconcelos, and he is a world authority in ocular toxoplasmosis. And he is one of the very prominent researcher in uveitis today. He did residency at the most prestigious Federal University of School of Brazil, fellowship in retina and uvea at UVFMG, and postdoctoral fellowship in ocular inflammation, immunology, and pathology in Doheny Institute, University of Southern California, 2008 to 2010, under Dr. Professor Narsingh Rao. And we have the same mentor. Currently, he is the associate professor and chairman of the ophthalmology and otolaryngology of UFMG, Uveitis Unit, Federal University of Minas Hospital. He has published over 100 papers in peer-reviewed journals, has several book chapters, 150 invited talks in scientific meetings. His research area of interest is non-infectious and infectious uveitis, musculates, tropical ophthalmology, ophthalmic pathology, and telemedicine. And today he will be talking on ocular toxoplasmosis, where he is the international authority on this subject. And it's indeed a privilege and pleasure to listen to him. Welcome, Professor Daniel, and we are all eagerly waiting to hear from you. Dr. Daniel.
Thank you so much, Professor. Thank you so much, Professor Biswas, for the generous introduction. Thank you for the colleagues of the University Society of India and so many good friends around. It's a privilege for me to join you in this wonderful initiative that is the iFocus. So our subject today will be ocular toxoplasmosis. Is an area in which I'm very interested in for several years. It is indeed a global zoonosis with very high prevalence in humans. Up to 1/3 of the human population is chronically infected with Toxoplasma gondii. However, it is usually a mild and self-limited disease in immunocompetent individuals, but may pose a significant problem in immunosuppressed people as well as in newborns after congenital infection. What is important to us ophthalmologists is that ocular disease is a major clinical manifestation of chronic toxoplasmosis in the human population. So that toxo is the major etiology of infectious posterior uveitis worldwide. It is now recognized as an important cause of blindness and has been suggested as a neglected tropical disease. The disease typically manifests as a retinal choroiditis with primary involvement of the retina and reactive inflammation of the vitreous, of the retinal blood vessels, as well as even of the anterior segment of the eye. The disease is recurrent and is particularly severe, as I said, in people who have compromised immune systems. What happens in toxoplasmosis-wise is that in primary acquired infection, we have dissemination of the parasite all over neural tissue, including our retina. So that we had sitting in the neurosensory retina in the latent form for several years after primary infection. So the cysts, they in normal conditions, they are balanced with the host immune response. But once the cysts rupture, they release tachyzoids that are the rapidly activating replicatory form of Toxoplasma gondii. These tachyzoids, they do release cytotoxic mediators. They also cause a direct lesion to the retina, but importantly, they elicit a robust immune response, which may lead to local sequelae inside our eyes. This is a section of a case from Doheny from the time I was there. So what we see here is a full thickness necrosis of the retina with Toxoplasma gondii cysts around, and this robust reactive granulomatous inflammation of the underlying choroid. What is interesting is that current anti-toxoplasma cysts, they only are able to kill taxoids, which are the active proliferative form of the parasite. They are not active against tissue cysts, which contain bradyzoids. Reason for which is not possible to eliminate chronic toxoplasmic infection. So what happens is that once we have active retinal choroiditis, we are able to treat those proliferating taxoids with antiparasitic drugs, but unfortunately, we are not able to definitely eliminate chronic infection, which is cysting in intraretinal cysts. It's also important to briefly mention that we have several different genotypes of Toxoplasma gondii. These are the canonical ones, genotypes 1, 2, and 3, which have a diverse distribution all over the globe. These different genotypes, they do vary in virulence. So types 1 and 3 are known as to be much more virulent than type 2. They also elicit a different pro-inflammatory response. They also differ in the tendency to insist in neurosensory retina, and also differ in drug susceptibility. Further studies have depicted several other subtypes of strains of Toxoplasma gondii, and it's interesting graph. We can look at the parasite diversity all over the globe. The more different numbers of colors we see are correlated to the increased number of different strains of the parasite. So if you look at South America, specifically in Brazil, we would have a significant number of different colors in this map, indicating how many different strains we do have back here. So we have the pathogens from the side of the parasite. As I said, we have more virulent strains which may cause some more severe disease. But from the side of the host, it's also important to mention that the immune status of the host is also important determinant of pathogenesis in the patient. So we have obviously the well-known immunomaturity and allergy of newborns. That's one of the reasons for which congenital toxo is associated with more severe systemic and local disease in these patients. We have several examples of immunosuppressive conditions, diseases, including AIDS, which also predispose the patient to more severe retinal choroiditis. And we have several studies showing that there are also some genetic determinants to the immune response, which may correlate to more severe retinal or systemic disease. These are data from the two larger epidemiological studies on uveitis in Brazil. This one on the left performed in our center. We looked at almost 4,000 patients with uveitis. This on the right from the Federal University of São Paulo, the major center located in São Paulo in Brazil. We see the uveitis back here in Brazil. It does occur predominantly in young individuals. It is frequently of infectious etiology because of toxoplasmosis. Here, 50% of the cases of uveitis we see in the Federal University of Minas Gerais are associated with toxoplasmosis. And even in these people, we have severe sight-threatening involvement. Around 1/3 of our patients do evolve with loss in vision in at least one eye. When we look from another perspective, from low vision referral centers, these are two studies performed in our center here. The one on the left with children, the one on the right with older children and adults. We can see also here that toxoplasmosis is the leading etiology of low vision in our center here in Brazil. There is an important controversy on the relative importance of acquired versus congenital toxoplasmosis on the pathogenesis of ocular disease. So until the middle of last century, all cases of ocular disease were attributed to congenital toxoplasmosis. After several decades with better documentation of postnatally acquired disease in adults, several studies performed here in Southeast Brazil have shown that postnatally acquired toxo is much more important than previously recognized, and probably implicated in most cases of ocular disease. Congenital toxo may lead to systemic involvement from introduction, death, abortion, growth restriction, to a severe neurological damage, calcifications, microcephaly, hydrocephalus. But what is important to mention is that up to 90% of the infected children may be asymptomatic at birth. The typical stadium status is seen in less than 5% of infected children. On the other hand, retinal choroiditis is the leading manifestation of congenital toxoplasmosis. We see in up 8 to 80% of infected newborns with toxoplasmosis. The lesions may be active soon at birth. So these are fundus pictures of newborns, 30-year-old newborns that I did examine several years ago that had active retinal choroiditis in the macula, as you see in these pictures. Some patients may have severe scarring soon at birth with extraction retinal detachment, bilateral here you see, as in this case. And some patients may have a mix of active and cicatricial lesions. Sometimes the diagnosis may be late. This is a fundus picture of an 8-year-old boy that was having his driver's license. When he covered his eyes, he realized that he could not see. And we can see this severely atrophic scar in the macula with chororetinal anastomosis also associated with toxoplasmosis that was diagnosed by 18 years of age only. It is a recurrent disease, so up to 2/3 of patients with retinal choroiditis do evolve with relapses later in life, as you can see, either close to or distant to previous red cards. Systemic disease in immunocompetent individuals, as I said, is usually benign. So toxoplasmosis is typically asymptomatic in immunocompetent people. It may present as a lymphadenopathy, with viral-like symptoms such as fever, malaise, myalgia, with severe systemic involvement being very rarely documented in this patient. If we look at these people soon after seroconversion, only 2 to 3% of immunocompetent people develop retinal choroidal scars consistent with toxoplasmosis. But as time goes by, what happens is because of rupture cysts, then retinal choroidal lesions begin to show up. So that up to 20% of these patients may develop retinal choroiditis later in life. As the immune system gets old, we may have atypical severe presentations, particularly in the elderly, and with frequently rates of recurrence, as I said, for these patients. Many years ago, we had the chance to look at simultaneously the fundus of newborns that had confirmed congenital toxoplasmosis and the fundus of their respected mothers that had probably acquired toxo, they transmit to the babies and then had the disease by the same parasite. And if we compare the fundus involvement in both settings, we see this striking difference. We found 80% of newborns with retinal choroiditis lesions soon at birth, but only 2.5% of their mothers with retinal choroiditis soon after seroconversion. So you see how different toxoplasmosis is depending on the mode of infection. In immunosuppressed individuals, as I said, retinal choroiditis associated with toxoplasmosis is recognized as much more severe, with associated with higher risk of complications, bilateral, multiple diseases, and also tendency to evolve to a chronic course. This is an example. This is from a 27-year-old female that came to our center a few years ago with decreased vision in the left eye. She had extensive hemorrhagic retinal choroiditis in the left eye. And because we were concerned about toxo, we did perform an AC tap, which was negative for viruses, but was positive for Toxoplasma gondii DNA. That was when we realized that she had recently HIV co-infection. This is another example of a young patient with HIV, normal CD4 count, and you see the extensive multiple retinal choroiditis lesions all over before and after treatment. And this last case of patient, young guy that came to our center with decreased vision, severe endophthalmitis in both eyes. You see like the small hypopyon here in the right eye with psoriasis as well. The anterior chamber was full of inflammatory cells with fiber inflammation. We barely could see the fundus, so we started him on topical steroid drops. We did perform an AC tap for viruses, which came back negative. But as the anterior segment began to improve, we could see some extensive foci of retinal choroiditis in the back. That's when we started antiparasitic drugs. He came also with a positive HIV, which was unknown until then. And he developed severe iris atrophy, probably because of the iris involvement, because of his immunosuppressive state. And this is, after treatment, you see the extensive retinal choroidal scars associated with toxoplasmosis. This is another case of an immunosuppressed lady. She was being treated for thymoma with chemotherapy. She developed lesions in the macula as well as in the periphery of the right eye. She also has significant nuclear cataract. And what we did is that we collected the aqueous humor, which came positive for Toxoplasma gondii DNA. She was then treated. And last but not least, two more examples of patients undergoing heavy stereotherapy. This is a young lady that was presumably treated for multiple sclerosis associated optic neuritis and developed the severe extensive retinal choroiditis in this left eye. The PCR came positive, but you can see also that there is this pigmented scarring in between the areas of active retinal choroiditis. And there's another another example of a patient that received a Nosrad implant and developed extensive retinal choroiditis, simulating a herpetic retinitis, but luckily the AC test came back negative for viruses and positive for toxo, and he was treated and improved vision. The diagnosis of ocular toxo is basically based on pattern recognition on fundus examination. So typically, we do have focal necrotizing retinal choroiditis, which variable vitritis sometimes we have this headlight in the fog kind of aspect because of dense vitritis. And this lesion, this active lesion, is usually adjacent to a pre-existing pigmented scar. That's why we call it a satellite lesion. Sometimes the choroidal scar is lacking. This does not rule out toxo at all. Of course, in this setting, it's very important to make a good differential diagnosis. This is the typical headlight in the fog lesion with a focal necrotizing retinal choroiditis, significant vitritis, without previously recognized chororetinal scarring, but still this is toxo. This is another patient that had a satellite lesion here just adjacent to another chororetinal scar. And we see two additional chororetinal scars probably associated with previous involvement from previous crises of retinal choroiditis that sometimes have not been recognized by the patient. There's some other associated features. Active toxo retinal choroiditis typically leads to multifocal retinal periphlebitis. We see sometimes the significant shifting of retinal veins. If the lesion is close to the optic nerve head, we may see optic disc edema, as in this case, sometimes macular edema and vascular occlusion, particularly if the lesion is located close to a retinal blood vessel. If the inflammation comes to the anterior segment of the eye, we may see keratosis precipitous, which may be granulomatous. We may see also anterior vitreous precipitous. Sometimes you see the same counterparts of multifat KP in the anterior hyaloid membrane. Diagnosis, as I said, it is clinical, but it is supported by systemic investigations. So we may recur to serology to confirm that the patient was previously infected or recently infected by Toxoplasma gondii. Serology is also very important to rule out other infectious etiologies which may lead to retinal choroiditis, such as syphilis, TB, and whatsoever. Multimodal imaging has been particularly useful to help us make a diagnosis of toxoplasmic retinal choroiditis because of the pattern that I'm going to show you in the next two slides. In atypical cases of more severe multiple lesions which may stimulate herpetic retinitis, it is important to get the aqueous humor and submit it for either a quantification of specific antibodies with the yield of so-called Goldman-Whitmer or Goldman-Whitmer coefficient, or to get a molecular amplification of the DNA of the implicated organism. So briefly, the Goldman-Whitmer, it does look at the intraocular synthesis of the specific antibodies to any infectious agent, including Toxoplasma gondii. When the eye is severely inflamed, we have to be very careful because the breakdown of the blood aqueous or blood retinal barrier may lead to leakage of specific antibodies to the systemic circulation. We also can look at molecular diagnosis. As I said, usually we have tried to amplify either the B1 or the RAP529 sequences of the Toxoplasma gondii genome. And what is important for Toxoplasma retinal choroiditis that is different from herpes viral retinitis is that the sensitivity of aqueous humor PCR is quite limited. So it's around 20 to 30, 40%. So a negative PCR of the aqueous humor does not rule out toxoplasmosis in recompetent individuals. Once we are able to get vitreous samples, then the sensitivity does increase to 60 to 90% of the cases. But if the individual is immunosuppressed, that also does increase the sensitivity of the PCR analysis. So this is another example of a patient that I saw a few years ago. She's an immunocompetent lady with ocular pain, decreased vision in her left eye for 1 week. So the vision was 20/70 in the left eye. We could barely see the optic nerve head, which was located here. And there was this large triangular lesion in the superior part of the optic nerve. This was a hypertensive uveitis. The IOP was up to 36 millimeters of mercury. This is her angiogram, which can nicely localize the retinal choroiditis focus. And what was also interesting was that she developed a vascular occlusion because the lesion was just close to retinal blood vessel. Here's the OCT showing some disc edema, some diffuse macular edema as well. And she had a significant exudate detachment of the retina at the superior part of the optic disc. If we go down with scanning of the OCT, we could find that in some areas we had a picture which would be consistent with a retinal choroiditis, with this focal hyperreflectivity of the neurocentral retina and this fusiform thickening of the underlying choroid. This is highly suggestive of toxoplasmosis, but we were not definitely convinced she may have had necrotizing herpetic retinopathy. We just decided to treat her with both schemes. So she did receive classic therapy for toxo, but also a high dose of ultras to make sure that she did not have a viral retinitis. We did an AC tap, we did take a few days, and here you see, just after 7 days of specific therapy, no corticosteroids at all, we can see that the vitreous did improve a little bit. We can easier see the retinal choroiditis focus, which is quite large. And then came back the serology. She was negative for HIV, a positive serology for toxo, but also for herpes virus, and negative PCR for toxo as well as for viruses. As I said, the sensitivity of PCR is much lower for toxo than is for herpes virus. So a negative HSV and VZV PCR in the context of patients with an extensive retinal choroiditis, it does make it very unlikely to be associated with herpes viral etiology. Still, we're not brave enough to stop antiviral therapy for this patient, but she progressively improved, as you can see here, reaching 20/20 after day 45. So this is the aspect of the angiogram. So the blood vessels perfused. This is the OCT before and after therapy. You see the almost normalization of the retinal thickening. And very curiously, 6 years later, that was last year, she came back complaining of floaters, and you see a satellite lesion just adjacent to that scar. So this is toxo. This is by no means herpes. So now I did treat her only with antiparasitic drugs, and she did very nice response. She did very nice response, as you can see in this pictures. So diagnosis of congenital toxo, it's more and more relies on serology, and we have to be aware because, as I said, subclinical infection is very frequent in these newborns. So we look at the serology of the mother and of the newborn. It's important to, if we have positive IgM or IgA, that does seal the diagnosis of congenital toxoplasmosis. If you find IgM and IgA in, this is self-production of antibodies by the baby, because both IgM and IgA are very large molecules. They do not cross the placental barrier. If we get negative IgM on IgA, still we're not able to rule out congenital toxoplasmosis because the IgM or IgA response may not be found in immunomatured babies. But if we find IgG is a smaller molecule, it may cross the placenta, So the mom may have seroconversion, may transmit the status, they still have only IgG. So how can we tell if this is congenital toxo, if the newborn is born with only IgG? We look at the kinetic of this specific antibody. If it is passive transfer of antibodies from the mom, what happens is that the levels of IgG, they will go down as the child grows older. So before 12 months of life, the child will probably have no IgG at all if this is passive transfer from the mother. If this is self-production of antibodies from the baby will have persistence of IgG beyond 12 months of life. So this would confirm congenital toxoplasmosis. In this small baby, so it's fundamental to very early look at the fundus of this baby because typically congenital toxo is very frequently associated with macular lesions, and also because, as I said, sometimes the baby is born with only IgG. So if the baby has only IgG, we don't have time enough to have the kinetic of antibodies. But we do see fundus lesions consistent with toxoplasmosis. This is diagnostic of congenital toxoplasmosis. So it's important to look at the fundus of these babies as early as possible, ideally with a lid speculum and or under anesthesia to make sure that we're not missing peripheral lesions as well. Looking at multimodal imaging, this has brought a revolution to our understanding of infectious uveitis, including toxoplasmosis. So as I said, the typical pattern of retinal choroiditis associated with toxo is that of reflective thickening of the neoresponsive retina and the red asterisk associated with this underlying fusiform thickening of the inflamed choroid. This is the typical retinal choroiditis pattern, which does recapitulate what we see in histology. So this is a pathology of the nucleated eye, which we see this focus of disorganization of the retina, of full thickness necrosis, and this fusiform thickening of the underlying choroid, which gets this granulomatous reactive inflammation. We can have the superposition of all the filters and autofluorescence images, as you can see. So this is a lesion which is localized here at the red asterisk, and we see even the interesting changes in the vitreoretinal interface. You see that how the posterior hyaloid is detached here, and we have this granulomatous hyaloid precipitate thickening in the posterior hyaloid and the fusiform thickening of the underlying choroid, as I said. This is another case of patients without pre-existing scarring, so that's when we have to make a even more careful differential diagnosis. But once we looked at the OCT, you see the vertical and the horizontal sections, you see the increased hyperreflectivity of the retina, some serous fluid, subretinal fluid here, and you see the beautiful fusiform thickening of the core. So this is definitely retinal choroiditis. We'll have to take toxoplasmosis into consideration for this case. The next case is to see the role of angiogram. This is the ICG, just to show how we have the hypocyanosis associated with the reactive involvement of the underlying choroid, as you can see. This choroidal change we can also see by OCT angiography. This is another case of patients with satellite lesions in which we see the fusiform thickening, and you see this flow void at the level of the choroid capillaries associated with inflammatory infiltration of the superficial choroid in this case. Congenital toxo is usually associated with colobomatous lesions. So this is a newborn that we have been following for several years. You see this complete destruction of the neurosensory retina with this colobomatous kind of change. Sometimes the fibrotic focus may be more thickened, as you can see in this other patient with congenital toxo and bilateral macular lesion. Fundus autofluorescence can help us a little bit to look at scarring of the lesion during treatment. So there's a patient on D0, you see that the active lesion, it almost does not show up. It's usually a subtle autofluorescent signal. And as the patient starts to respond on therapy, what happens is that we see this hyper autofluorescent halo, which does increase and is surrounded by a more marked hypoautofluorescent halo as well. And after several weeks, what happens is that the lesion becomes completely hypoautofluorescent. So we may recur to autofluorescence to look at retinal scars. However, not every yellow-white association nephritis is toxoplasmic, as you all know. So it is very important to make differential diagnosis in two contexts. In the context of small newborns with a suspicion of a congenital infection. So that's when we have to think about the so-called FORCE acronym that stands out for rubella, TMZ, herpes, syphilis, also West Nile and the specific cardiomyopathy virus, and more recently has incorporated the Z letter from Zika, which may also lead to retinal changes. We have to make sure that the patient does not have malformations, particularly congenital coloboma, which may be associated with some genetic changes, as well as different tumors. This is an example of a small baby that I did examine several years ago with this cavitary retinoblastoma in the macula, which may simulate a toxoplasmic kind of lesion in the macula. We had the Zika virus epidemic a few years ago, and some of the lesions which were reported in studies, major coming from Brazil, did resemble a lot the lesions that we saw from toxoplasmic retinal choroiditis after congenital infection. So you see how many of those scars, they really look like a toxoplasmic retinal choroiditis lesion. We did question this a lot because this is an example of a child that I do follow for several years. She was born with microcephaly, with just this atrophic scar, which was very easily confounded with Zika. And she was born only with IgG. So it's very important to carefully interpret serology in this patient, because if you don't find IgM or IgA, this does not rule out toxoplasmosis. So it's important to follow these children. So I have the impression that some of the children that were labeled as having Zika virus syndrome with retinal involvement have had indeed toxoplasmosis, toxoplasmic congenital toxoplasmosis, and they have had a mistaken diagnosis. This is another example of a child that is born with the atrophic lesion. Another one with torpedo-like kind of lesion that was being attributed to Zika as well. And this child, you see, 4 years later, she not only has this typical pigmentation of the lesion with this wagon wheel scar kind of pattern, but also develop a reactivation nasal disease. So this is definitely toxoplasmosis and not Zika at all. In the context of adults with either recurrent congenital or postnatal acquired toxo, it's also important to make a careful differential diagnosis with other infections. Retinitis, retinal choroiditis, either bacterial, viral, fungal, or parasitic. It's important also to rule out other non-infectious uveitis with or without systemic association, like sarcoidosis, for example, and also make sure that the patient does not have a masquerade syndrome. The treatment of ocular toxo is based on a combination of antiparasitic drugs and corticosteroids, and the decision to treat is usually based on the immune status of the individual, on the location of the lesion, on the degree of arthritis, on the visual acuity, as well as on the clinical course. There are several papers in the literature questioning the evidence to treat toxoplasmic retinal choroiditis, because the disease may be self-limited in the competent individuals. Many people do question whether it is necessary to treat patients with toxoplasmic retinal choroiditis. However, there is no randomized control study, and it would be unethical to have so, comparing patients receiving placebo to patients receiving antiparasitic drugs and steroids. And I have to stress that the lack of evidence to treat should not be interpreted as an evidence of the lack of necessity to treat. So we usually treat the patients because they may, the active lesion may result in severe choroidal damage. Newborns with congenital toxo, immunosuppressed individuals, and pregnant women, we do always treat them. Allergic individuals have to be very careful. By far, sulfa allergy is one of the most common side effects of therapy in this patient. So this is an example of a newborn, a 60-day-old newborn, which I did examine in the many years ago, that had active retinal choroiditis in the macula. Imagine if we would not treat this child. So this is the aspect of the lesion 4 years later. She was treated, and you see the vision was 2063. We see this result. It's not a large lesion at all. The vision is still 2063 after treatment. This is another patient. This is a patient with postnatally acquired toxo. This is a perimacular lesion. You see how the lesion nicely scars down under treatment. And this is the OCT aspect of the therapeutic response. You see the typical retinal choroiditis kind of pattern. You see along and after treatment how the lesion nicely responds. So we do have a large arsenal of different drug combinations to treat toxoplasmosis retinal choroiditis. The most famous is so-called classic therapy that is composed of sulfadiazine, pyrimethamine, supplemented with folinic acid. We may use a combination of pyrimethamine with azithromycin or clindamycin. We may also use the sulfamethoxazole trimethoprim, so-called Bactrim, to treat toxoplasmic choroiditis. But it's important to consider the use of systemic corticosteroids in these patients, usually to be started 48 hours after institution of antiparasitic drugs and to be stopped before we stop antiparasitic drugs in these patients. I personally do prefer classical therapy, particularly in more severe cases, for several reasons. First, because by far this is the most effective therapy in experimental models of toxo. This is also the first choice of ID specialists in delicate situations, such as neurotoxoplasmosis, as well as congenital toxoplasmosis. Third reason, with some frequency, you see in the next slide, I do see patients which are receiving alternative therapies which are not responding, and when I put them on classic therapy, they do respond quite well. And last, because we do have a few randomized studies comparing these treatments, but usually the number of enrolled individuals is quite small, from 30 to 40 individuals, so it's not possible to tell unless you have a very large difference between the therapeutic regimens. So this is an example of a lawyer that has been treated with Bactrim for several weeks, was not responding. You see significant vitritis in the right eye. You see there was an active lesion here adjacent to an atrophic choroidal scar. There was a scar in the contralateral eye. And once we put her on classical therapy, she finally responded to scarring of the lesion here and improvement of the vitritis. We also may use intravitreal therapy in specific circumstances. We combine clindamycin and dexamethasone, so it's not to be the corticosteroid, not triamcinolone, has to be dexamethasone because the half-life of clindamycin is also very short. So we want to make sure that there is antibiotic coverage as we use the intravitreal corticosteroid. It may be employed for selected cases of intolerance, contraindication to stent therapy, or even lack of response. However, we don't have enough data on what will happen to these patients on the long term if recurrences are more or less frequent than on patients receiving systemic therapy, and we don't know what happens. I have the impression that the therapy is not as effective as systemic therapy. This is an example. It's a 22-year-old female woman which got pregnant. She came to us when she had a five-week gestation, and she was low-terse and decreased vision in the left eye. The vision was 20/25, and you see this active lesion just satellite to a pre-existing retinal choroidal scar. It's a peripheral lesion. She does not have significant vitritis. We would be able just to follow her because it's not active recent seroconversion. But we decided to treat her. We were quite concerned about using antiparasitic drugs, pyrimethamine, drugs which may be teratogenic at a very early period of gestation. And indeed, even if we use a safe drug, because it's for a long period of time, this may be implicated with side effects in the mother. So in this case, we are usually more conservative. So we decided to try to propose intravitreal therapy, and that's what we did. Actually, the vision was 20/40, sorry, at baseline. So we did perform a single intravitreal injection of clinda and dexamethasone. This is the response. You see that the lesion does decrease in size, but it is a quite slow response. You see that on 8 weeks, by 8 weeks, the lesion is already scarred, but you see it's still a little bit whitish. The lesion is back to 20/20 still, but you feel that the response is not as fast as with systemic therapy. And last but not least, for this, we have robust scientific evidence, secondary prophylactic therapy, secondary prophylaxis for toxo. So we have 2 clinical trials showing that intermittent backtraining is able to prevent relapses of retinal choroiditis in patients, at least during the time that they are using this data. This is the first drug. This is the first study from the group of São Paulo, which we found drastic difference between the relapse in the treated group when compared to the placebo group, the untreated group, and this is a placebo-controlled study also in the city of Campinas, also in São Paulo, with a long follow-up showing that patients had a significant reduction of the risk of recurrent retinal choroiditis. The question that comes is, for how long are we going to use? So the regimen is sulfamethoxyl. We're using two different regimens, either 3 times a week, as in the first clinical trial from São Paulo, or every other day, as in the other clinical trial from Campinas. Usually in patients, the ones which are immunosuppressed, the ones which have frequently recurrent lesions, bilateral involvement, unilateral multifocal involvement, or even threatening immune threat to the macula itself. But the question that comes is, for how long are we going to keep this patient of prophylaxis? Is it for a whole life? If we look at prior studies of natural history of toxo, and also if we look at the studies from the group in São Paulo and in Campinas, we see that the recurrences that did happen, they did happen specifically in the first 2 years of life. We have a 15% risk of recurrence in the first 12 months after the last recurrence, and a 5% risk of recurrence in the subsequent 12 months. So it's important, as when we decide to start prophylaxis, I usually tell the patient, you know what, we're going to try it for 12 months. If it's okay, we can extend for 12 months. Then after these 2 years, the risk of recurrence goes down. So that's when we can stop systemic therapy, systemic prophylaxis with some level of safety. So this is an example. This is a 17-year-old, actually was a professional soccer player. He had been just drafted for the Brazilian national team, the sub-17 team. And he was complaining of decreased vision floaters and loss of thyropsis. Actually, he used to play the defense, and he was losing the time of the ball. He could not tell the distance of the ball, and then he came to me. He had some inflammation in the front part of the eye, but some significant vitritis. As you can see, the vision was down to 20/60, and he had this active focal retinal choroiditis just below pigmented pre-existing retinal choroidal scars. So this is typical of toxo. We decided to treat him. We had the big deal because he was on the national team, so they were doing the anti-doping test. So he had to have an authorization from the national team that would allow him to take the medication. It was getting worse and worse and worse, so we had to try to hurry that up. But so he responded very nicely, as you can see here. So by week 5, he was 20/20, vitreous completely transparent. But then a question comes. He has just been selected for the national team, has just became professional. What if he gets another recurrence? So we discussed with him the possibility of prophylaxis, and we decided together to start from a prophylaxis. And it's been now almost 2 years that he's on intermittent backtraining without any further recurrence in this left eye. So this just to show that more recently we have been more flexible towards prophylaxis in this patient. So we got into the end. How do we prevent toxo? It is such a ubiquitous parasite. It's very difficult to be able to prevent it. Usually preventive measures are usually tailored to pregnant women, which are the ones that have the risk of more severe disease if their babies get infected. So this is what we tell the pregnant women which are still negative for toxo to be careful about. So to avoid drinking unfiltered or unboiled water, to avoid raw or undercooked meat. Any meat for any warm-blooded animal may be contaminated with Toxoplasma gondii. On the other hand, if we freeze the meat, that does inactivate the cyst. So in large cities, when the meat is previously frozen, the risk of toxoplasmosis significantly decreases. To wash fruits and vegetables, because sometimes contamination comes from oocysts that are contaminating soil, and then they get to the fruits and vegetables. And also use gloves and wash hands after manipulation of both raw meat as well as soil. Also importantly, because the infection may be asymptomatic, we usually screen seronegative women during gestational. The best screening program in the world is in France. They do screen the moms every month for toxo, because there's evidence which shows that if you defer treatment for more than 1 month, that does not prevent transplacental transmission and subsequent infection of the fetus. If we look at the risk of transplacental transmission, it's quite low in the beginning of the pregnancy, it's around 10 to 25%, but it gets to almost 70 to 80% in the 3rd trimester. The systemic sequelae, however, they are inversely related to gestational age. So that if the infection is early during gestation, that's when the child gets microcephalus, intracranial calcification, intrauterine growth restriction, and some other systemic involvement changes. However, if you look at the rates of retinal choroiditis, it is stable all over the station. Children may get retinal choroiditis. They are infected both in the 1st, in the 2nd, or in the 3rd trimester of the station. So the risk is constant all over the station. And as we detect the seroconversion, it's very important to treat the mother to prevent transplacental transmission, then to test the fetus for infection, and treat the fetus with classic therapy to make sure that we have decreased systemic and ocular sequelae in these babies. So finally, the prognosis of ocular toxoplasmosis is quite variable, as we may imagine. It may vary depending on the size, on the location of the retinal choroidal focus, on the recurrent nature, how many episodes, how many relapses the patient has had all over life, and the resultant cumulative damage of these episodes of intraocular inflammation. Obviously, it does depend on the occurrence of complications, retinal detachment, retinal fibrosis whatsoever, on the host immunity and on the parasitism, as I said. But there are also some other variables involved. So a few years ago, we looked at the visual-related quality of life and depressive symptoms in patients with toxoplasmosis. There is a very interesting theory, at least in animals, that hypothesizes that animals which are chronically infected with toxo, they get some CNS changes. They are more likely to be predated by cats, for example, if these are mice. And there are some theories also that Toxoplasma gondii infection may change human behavior. So there's some cohort studies in the UK, for example, showing that the prevalence of car accidents is higher in patients which are chronically infected with gondii. This is some sort of conspiracy theory in my modest view. So I decided to look at a few years ago on the visual quality of life and also depressive symptoms in patients with ocular toxo. And what we found was that ocular toxoplasmosis is significantly associated with compromise in the visual-related quality of life. This is a function of the visual changes, visual deficiency associated with toxoplasmosis. So usually the patients that have affected visual-related quality of life are the ones that have decreased vision associated with toxo. But what was surprising to us was that these patients, they are very frequently depressed. The rates of moderate depression was twice more common in patients with ocular toxo, and of severe depression 3 times more common in patients with toxo than when compared to 200 healthy age and sex-matched controls. We also had the chance to look at the controls themselves to see this theory of behavioral changes. So we had 200 controls, which were evenly distributed. Half of them were seropositive, and half were seronegative for toxo. And what we found was that no difference whatsoever on the prevalence of depressive symptoms when we compare seronegative versus seropositive patients. So very likely the depressive symptoms associated with toxo are mediated by severe ocular disease associated with it. So it's definitely not a problem that we may overestimate. So in conclusion, many years ago, Professor Jacob had made this question whether we believe in the seat of toxoplasma. I definitely think that in Brazil we do, but it's a paradox that it's present all over the world. It is a neglected, treatable disease with a high frequency, a heavy burden of progressive ocular changes as patient has relapses all over life. there is a risk of subclinical involvement. I showed several examples of patients that were not aware that they had toxoplasmosis until they had an active focus of retinal choroiditis. So there is definitely a risk of negligence. It's possible that the parasite genotype will influence outcome. So it may be in the future, the treatment for toxoplasmosis may vary depending on the type of strain that is infected the patient, him or herself. So it's very important to talk about toxoplasmosis to increase public awareness. So in this context, I'm very grateful to you all to invite me to come over to speak about this subject, which does interest me a lot and which is very, very important and very fascinating. So that said, I thank you very much for the opportunity to speak to you, and I'll be more than happy to discuss and to have prolific interaction with you in the last few minutes. Thank you very much.
Wonderful talk, Daniel. Wonderful talk. We learned a lot. We learned a lot.
Thank you so much, Dr. Biswas.
Thank you, Professor Daniel, for comprehensively covering such a difficult topic because there are so many varied presentations, and you have covered everything from the clinical features to treatment to prevention and how it affects the quality of life. There are some questions from the postgraduate students. So we'll go on to the questions now. The first one is, how to differentiate toxoplasmosis from fungal retinitis, specifically when there is not much vitritis?
Well, that's a very interesting question. As a matter of fact, I had a case many years ago for fungal retinitis. Actually, the patient did present to me with marked fulminant endophthalmitis, but I did have access to the first fundus pictures. And at first, it did look like a focal of retinal choroiditis. So it's a very interesting question. So first tip, I think, if you find pre-existing pigmented scars, it's very likely toxo. So a satellite lesion is prototypical mode. I think that the major concern would be if you have a focal lesion without pre-existing scarring. The OCT may help if the fungus is Candida, for example, it has some tropism for the vitreous. And if you have the OCT, you see that what they call the rain cloud sign, which is a change in the vitreoretinal interface, which leads to some shadowing in the retina, and usually the retina is not that much altered. So for Candida, it is not a big deal because usually Candida has significant tropism for the vitreous. Very early, it may lead to those typical vitreous scrolls, which are quite suggestive of Candida infection. If you look at filamentous fungi, that's when we have a problem, because Fragilus, other filamentous fungi, it may grow to the subretinal space, and sometimes the very initial lesion, it may be confounded with Toxoplasma retinal choroiditis. So what do? I usually order serologic tests, and if I'm able to start with an empiric therapy, I do start therapy without steroids. So if I'm not convinced that it's not toxic, I don't use steroids at all. So I think it's very wise to start only specific therapy and follow the patient. If you start specific therapy and the patient is getting better, so that's very unlikely to be fungal, we are okay. If you start therapy and the patient is getting worse, then it's probably not toxoplasmic retinal choroiditis. And obviously, if you're thinking about a fungal infection, we have to work up the patient systemically. So look at blood cultures, urine cultures, look at echocardiogram, to look if there is any vegetation involved. We have to try to find a focus either in the lung or somewhere else, which may be associated with that retinal foci.
Thank you, Professor. That's a very important point, not to start steroids unless you are sure of the diagnosis. Thank you for that. What is the role of toxoplasma antibody titers in the diagnosis, Professor?
Well, we have two major roles of it. First is to show that the patient has chronic infection. So, and that's when we have ocular toxoplasmosis. So, if you have, I'm very much interested in the negative predictive value of serology. So, if the patient is IgG and IgM negative, then we rule out toxin definitely. Even immunocompetent, immunosuppressed, this is very important because the books say that if the patient is immunosuppressed, he may not have an IgG response. After more than 20 years of practice, I have never seen a single patient with toxo, with ocular toxo, which is seronegative for toxo. So, I mean, we have exceptions, of course, a patient that had a bone marrow transplant, for example, and whatsoever. So it depends on the degree of immunosuppression. But usually, if we don't find antibodies, IgG and or IgM or IgA, this is not toxo at all. So the negative predictive value of serology, or the positive predicted to indicate recent infection. So, for example, a patient that I had a case that received a pork meat as a gift from a neighbor and started to have fever, lymphadenopathy, and lost the vision in one eye. Had the macular active lesion. I got the serology. It was IgG and IgM positive. That indicates that this is recent seroconversion. Still, we have to be very careful because more recent assays, fluorescence assays, they're able to pick up very low levels of IgM antibodies years after seroconversion. So we have to look at antibody titers as well. So if the IgM titer is very low, this is probably not recently acquired infection. It's recently acquired only if IgM is very high, and if we have IgG with low affinity. So it's also possible to assess the degree of avidity of IgG to the antigen. So as the immune response it gets more mature, then the antibodies get very avid to the antigen. So if we have recently acquired infection, then the IgG is not that avid to the antigen. So it's able to quantify the degree of IgG avidity also. This may also be indicative of recently acquired infection. So that said, in most instances, what we will see is a patient with only IgG. So because if you're in a highly endemic area such as Brazil, this becomes a big issue because a patient, if we have 80, for example, in my city, it's 80% of seroprevalence. So patients may have fungal endophthalmitis, they may have TB, they have any type of infection on infectious uveitis, and still may be chronically infected with Toxoplasma gondii. If you go to a low prevalence area, that's when the positive predictive value of serology becomes more important. But still, the diagnosis is predominantly clinical. The serology is not that much helpful unless to rule out the diagnosis of toxo if the patient is seronegative.
Thank you, Professor. The next question is, what is the endpoint of treating Toxoplasma retinochoroiditis if after 6 weeks of anti-toxo therapy, the lesion is still in the healing phase? Do we continue the therapy with anti-parasitic drugs, or can we stop? When to stop?
Well, that's a very good question, and it's important because many times the vitritis, it does take time to improve. Sometimes you may have residual vitritis for months after, and this is not indicative of active toxoplasmic retinochoroiditis. Another very important point: we don't wait for the lesion to be pigmented to affirm that it has scarred down. So we look at the margins of the lesion. So usually, as the patient responds, the margin flattens down. So the lesion gets very much demarcated. If you got an autofluorescence, you see that this sharp halo of decreased hypoautofluorescent signal around the lesion. So that's good enough evidence for us that the lesion is not active anymore. In addition, usually the vision gradually begins to improve. So if the vision is getting better, if the lesion is very sharply demarcated, has this decreased hypoautofluorescence halo. This is for us definitely that the patient was sufficiently treated. So on a time-wise basis, usually we treat this patient for 35 to 45 weeks. So it's usually from 5 to 6 to 7 weeks overall. Immunosuppressive individuals we usually treat for more time, sometimes 8 to 12 weeks, depending on the case. So if the patient is immunocompetent, usually a course of 35 to 45 days of therapy is definitely sufficient to kill active proliferation, tachyzoids, and to modulate the immune response there so that afterwards the patient is able to spontaneously recover by himself.
Okay. Thank you, Professor. So the last question for the session is, in case of recent past history of toxoplasma retinochoroiditis, if patient wants to conceive, do we as ophthalmologists need to advise any particular interval between the retinitis and conception?
Oh, that's also a very interesting question. Well, first, it depends on whether the retinal choroiditis was associated with recently acquired toxo or not. Why is that? Because usually the transplacental transmission of toxo occurs as the mother is primarily infected with the parasite. So this is a seronegative mother that gets infection during or close to pregnancy, and that's when she has parasitemia, and this parasitemia may cross to the blood the placental barrier and get to the fetus. So if the mother has chronic toxo, just IgG, the primary infection was years apart, the risk of transplacental transmission is very, very low, unless the mom has immunosuppressive state, for example, HIV infection. So this is a situation in which you may even consider prophylactic therapy depending on the gestational age. So that said, if this is a recurrence of chronic toxo, then it's not necessary to advise the patient. Actually, we can tell, I usually tell the patient, you know, the risk of transplantation transmission is very, very, very low. So you don't need to treat, you can just follow the patient. But if the patient had recent infection, that's usually when we wait for a few months, because some may have persistent parasitemia over some months, and sometimes they didn't treat the patient before he decides to conceive. So that's the point. In our experience, we did look at population-based prenatal postnatal screening for toxo many years ago, and out of almost 200 babies which were screened by the blood prick test, we had just one that was the result of transplacental transmission because of reactivation of retinal choroiditis during pregnancy. So this would be a risk of 0.5%. So this is very, very, very low. So that was from a woman that had reactivation of retinal choroiditis during pregnancy, had eye lesion. They decided not to treat her, and the baby was born with active lesion in both eyes. But this is so rare that it was published. So it's something that we have to discuss with the patient, but to let her know that it's very, very rare event.
Thank you so much, Professor, for your time and effort.
I've got two questions.
Sir, sorry. Yes.
I've got two questions. Is that one? Have you seen toxoplasma presenting as the initial manifestation of diffuse anterior uveitis with started KPs? I have got two cases where I confused with even TB. They have mutton fat KPs and all. I couldn't see the fundus. I was treating, I did a PCR. PCR for TB was positive. And later on, when the inflammation of anterior segment resolves, and I could see that toxoplasma lesion. The presenting as an anterior uveitis, have you seen as severe anterior uveitis?
I have seen, Professor Biswas, but it's also very rare. Over all those years, I have seen only 2 cases of patients with granulomatous anterior uveitis, which were associated with toxo. What I see much more often, sometimes the patients come to me with diagnosis of, for example, intermediate uveitis, because the vitreous is not clear, has some inflammation in the anterior segment, and if we do scleral depression, we see an active lesion, very peripheral one. So it's usually, anterior uveitis is very rarely rarely associated with toxo. I usually even don't work those patients up unless they have, and I have seen that in patients recently acquired toxoplasmosis. And I have tried to tap them, but unfortunately, the AC tap was negative for toxoplasmosis. So still, I could not tell. It might be some reactivation in the front part of the eye. What I have seen, we have been able to examine some patients from outbreak in the state of Minas Gerais. Is sometimes I've seen some patients that the lesion at the entry of the parasite in the eye is a very subtle infiltrate in the inner retina that very, very easily goes overlooked. I have gone to some initiatives in countryside cities with outbreaks of toxo, and sometimes the residents come to me, oh, Daniel, the fund is normal. And then I see no, there is this very mild temperature all over. We have published this in emerging infectious diseases a few years ago, from this multimodal imaging out of an outbreak of postnatally acquired toxoplasmosis. So what may also happen, what is much more frequent than toxocosm and uveitis is when we are not able to see the lesions because the fundus is very hazy, it's not easy to see, and that's a situation which is much more frequent than to have until you guys are able to talk. But it's possible, as you have this case, I have a couple of, but these were only two after several years of seeing thousands of patients with toxo.
Excellent, Daniel.
I just another case which has got a peripheral toxo. It looked like toxocara, and subsequently the patient developed posterior pole toxoplasma. Do you have such experience, peripheral toxoplasma?
Yes, I do. And it's interesting because some patients may develop a kind of fuchs-like response. Like salad KPs, sometimes they come labeled diagnosed with fuchs. And then I look at the back, you know what, there is a lesion here. I just recently a doctor, he is a 90-year-old pediatrician. And during the pandemic, he developed idiopathic thrombocytopenic purpura. So he had to receive systemic steroids. And he has a macular scarring in one eye, so he's monocular, and he could not see with this monocular eye because of this vitreous haze. So he came to me, and he had a diagnosis of fuchs many years ago. He was even to San Francisco to treat with Professor Kimura Taiko many years ago. And he came to me, he's a 90-year-old guy with congenital toxo. And what he had was a peripheral exudative focus of retinal choroiditis, which was reactivated because of systemic corticosteroid. He had such like a fuchs-like response in the anterior segment. So this is a very interesting observation of yourself. I think it does happen.
Hi, Daniel. I have a question for you. That can toxoplasma present with only vitreitis, or in a case like where you see a pigmented scar and there is a lot of vitreitis? So can it be a manifestation of activated toxoplasmosis, only vitreitis?
Well, that's a very nice question, Partho. Actually, many years ago, Rubens Belfort and Gary Holland did report some patients with recently acquired toxo and lesions, ocular lesions, which were inflammatory, but were not associated with necrotitis and retinal choroiditis. And even actually, I think that one of these patients had a vitritis. I think it's very likely that there is an unseen focus of retinal choroiditis somewhere in that retina. So as the lesion, as the vitreous begins to improve, maybe you can have wide field imaging and autofluorescence. I think it's very unlikely to have isolated vitritis. What I have seen, as I said, in patients with priorly labeled intermediate uveitis, as you very carefully examine them, scleral depression, sometimes you can see a very peripheral focus or a scar there that was associated with prior reactivation.
Thank you. Thank you,
Dr. Daniel, I have one question. Basically, if you see, most of the drugs for toxoplasmosis are acting on tracheozoids. Now, is there any drugs which can be used for bradyzoids, because they are the latent infection, and no, because accessibility of the drugs because of the hard capsule of the bradyzoids and the eccentric nucleus, posterior nucleus position, apart from the tracheozoid, which is centrally nucleus, changes. Do you have any explanation why we could not develop drugs for bradyzoids?
Well, that's a fantastic question, Dr. Well, actually, this is an enigma to us, because even many years ago, they did develop a drug which was known, at least in vitro, to be cysticidal. It did kill cysts. But when they did clinical trials tested, they see that it did not work. It just treated the reason that for which the current drugs, they are not able to kill the cyst, is because the cysts are such a latent form. It does not replicate very slowly. and you have so many inside the so many bradyzoids inside a tissue cyst that you're just acting on the ones that are replicating at that moment, because usually these antibiotics, these antiparasitic drugs, they do even act on folate metabolism. They usually work when the cells are replicating, when the organism is replicating. So because bradyzoids, they do replicate so slowly, so probably kill 1 or 2 in 1,000, 5,000 bradyzoids that are inside the cyst. So for some reason, any of them may rupture, may activate, may convert into tachyzoid, and may lead to relapse of retinal choroiditis. So this is one of the most important goals that we have in toxoplasmosis, to try to find the drug which might be cysticidal, which will be able to definitely eliminate tissue cysts in the retina, and which could hopefully be able to definitely cure ocular toxoplasmosis. So this is a dream that all of us have, and we really hope to be able to have this one day.
Thank you, Dr. Daniel.
Thank you. Thank you.
You're welcome.
So if there are no further questions, I'd like to thank Professor Daniel once again for his time and effort for this presentation and giving such an excellent talk and patiently and beautifully answering all the questions. Thank you so much, Professor. And over to Rolika and Team iFocus.
Thank you so much, ma'am. It was a wonderful lecture. And we meet next on the 8th of February for the topic being uveitis in children by Dr. Rathinam Shivakumar. We really hope to see you across from 26th of February to 5th of March at New Delhi for the physical iFocus, which is back. And we request all the postgraduate students to please follow the Instagram page, iFocus Online, for a recap of all the older episodes starting this Sunday. Thank you so very much, and a very good day to Dr. Daniel, and good night to all our fellow colleagues here. Thank you.
Thank you.
Thank you very much. Good night to all of you.
Dr. Daniel. Thank you.